We'll start with the first one that's kind of the odd one out. So if someone wants to come up and be my patient, you would go in supine in the middle of the bed. Thank you. All right. So this first technique is called the long sit method or walk around method. Either terminology is things that you'll hear or see in your lectures. Walk around method, long sit. The purpose is to get a patient from supine to seated edge of bed. In order to use this technique, a couple things have to happen. Your patient needs to have adequate strength in both arms. That way they can push up on them. And they can only have one or unilateral lower extremity involvement in the injury. Okay? These are your hip patients. These are your knee replacement patients. These are unilateral fracture patients, lymphedema, things like this. Things where one leg is affected, but generally the rest of the body is strong and able. Okay? These are the patients you can use this technique for. So to set us up, patient, we're going to get the pillow out of the way, always. We are going to, let's say, which leg do we want to be injured right now?
Left leg.
Left leg. So I am on the patient's affected side always. So if I'm getting a patient up out of bed, we are always, as the therapist, going to be positioned as close to the affected extremity as possible. That way, say the right leg was hurt, I'm not reaching further away than I need to. The limb that I'm going to be supporting is close to me. And also, the side that is injured is going to be the side of bed you get up on, ideally. Can you go the opposite way? Sure. Will it be ideal for your body mechanics or the patient's abilities? No.
Also, it'd break their hip precaution.
If they had hip precautions, you could potentially break them by adducting. Are you guys familiar with posterior hip precautions? Good. That we'll talk about that later on. Okay, so right leg's affected. Say she had a knee replacement. Familiar with knee replacements from your other course, or just in practice?
More in practice.
Okay. Knee replacement involves a huge scar, anterior knee. It's about 9 or 10 inches long. Very tender. You don't want to touch it. You don't want to put anything on it. But there are no formal precautions. Everyone asks, because there's hip precautions, are there precautions for a knee replacement? No. Okay? We want to facilitate extension of that knee, because that's the first thing that they're going to lose. And if they lose extension, then there's no purpose for what the surgery just did. Okay? So it has a tendency to contract and get tight like this. So the only rule is no pillows behind the knee. Okay? That could be on your test. So knee replacements, you may see nurses who walk into the room and they've got a pillow behind that knee because the patient asked for it and the nurse didn't want the knee. They said, oh, it's comfortable. But all you're doing is facilitating the contracture of that knee. So we always want to facilitate extension of an affected knee. So there's no issue with anything that we're about to move. It can bend, it can straighten, you can lift distally to the knee. It's fine. Okay, so knee replacement on the left. We got to get her up. I want her to help as much as we can. The movements are going to be up onto elbows, extending up onto the hands, face the fingers away. That way you're not putting excess strain on the flexors of the wrist and fingers. So fingers back. Then she will flex her right knee, put her foot flat on the floor, or on the bed. I'm standing on the affected side, and I'll be supporting the affected leg distal to the knee. That way I take the weight of that leg. Before the patient moves, we talked about trunk contact inside line. Same thing goes when we're sitting up. I always have to have a hand on the patient before we move. Okay, so I can't tell her to go ahead and sit up and then say, oh, I forgot. There's a momentary lapse, it's a safety risk. Okay? So hands on the shoulder. Go ahead and come up onto your elbows. Good. And then come up onto your hands, face your fingers behind you. Good. Okay, so she's here. My hand is up on top of the shoulder like this. That way, let's say she was a hip replacement patient. I could stop her with the front of my palm from coming too far forward, and I could stop her effectively from falling backwards by pulling from the back side. That's why you're over the top of the shoulder. Okay? Not on the side, not on the arm that's mobile, up on top of the shoulder. Okay? She's gonna bend this leg up. That way she can push and drive. This leg I'm gonna be supporting. I'm not jacking it up for any patient, but of course for a hip patient. All I'm doing is unweighting it from the surface and then we're moving at her pace. We're gonna start pivoting towards me to sit at the side of the bed, and I'm just gonna follow you. So I'm moving with her. Once we're here, we're gonna lower the bed down to the floor, because what's the next step? Get him up, get him out of bed. So I'm gonna find the correct, let's see if it's correct control. You can tell me if I'm doing anything wrong. Find the hands, right? So let's raise it back up. What can I do instead?
Scooter forward.
What else? Do I still need to have a hand on this leg?
Not if it's
No,
can
right?
Just under
Those
forward.
knees can bend, especially if it's a hip. All I'm gonna be doing is hiking the hip up. So I'm gonna let go slowly, make sure they're ready for it, because it will be painful. Knee can bend, you can let go, want to protect yourself, and then you can lower it down from there. All while maintaining trunk contact, because from here, that hand's never gonna leave the patient until they're seated in a loop chair.
So they'll swivel over and then you can say, I'm gonna start lowering your leg
Yes.
and then
Yep,
lower.
and then that way you can stand back up,
Okay.
you can lower the bed as you need to, or on the hospital beds, you lower it like this, hold on to the patient. Okay? Once their feet touch the floor, then you're ready to do transfers. Okay? Alright, that is the long sit walk around method. Any questions? Therapist is always on the which side? Affected side. And which side do we pivot towards? Affected side, right? Because otherwise you're rotating away or you're having to walk around the bed. You're always rotating towards that affected side. You always have 2 points of contact on the patient during this. One supporting the affected limb, one's up on the shoulder, and that shoulder does not leave until they're in their new position out of the bed. Okay? So always, we are not lifting them up. This is an able patient. Like I said, only one leg can be affected. If there's 2 legs affected, or if their arms are weak, this is not the technique you'll choose. Okay? Go ahead and practice this. Should be pretty quick. We'll do the next 2.
Alright.